All right, so now we have to discuss about the third type of that one, that is the type 4 RTA, the hyperkalemic renal tubular acidosis. And you can just remember it all with a one keyword, that this is the problem into the aldosterone production, or the problem is related with the aldosterone. So this one is actually different and sometimes not to be considered as a defect in the tubule's ability to handle the bicarbonate directly, but instead of that, it actually stems up the problem for just the aldosterone and its actions, right? So remember the principal cells in the collecting duct. Okay, get back to all that concept. The aldosterone derives the sodium reabsorption, and in doing so, it is also creating the luminal negative charge voltage, right? That is actually driving the potassium and also the hydrogen secretion. We have learned that immensely into the ROS system also. So the aldosterone has the two critical effects. The first one, of course, it is lowering the potassium, right? It is lowering the potassium. How? By secreting it out, by secreting it. And it also lowers the hydrogen ions. It is also hydrogen ions by creating the gradient for the hydrogen secretion. So now what happens if you have the hypoaldosteronism? Hypoaldosteronism means the lower levels of the aldosterone, and you do have the aldosterone resistance, means that the principal cells are not going to respond to it. So let's just try to predict up all this situation, what is going to happen it up, right? A hyperaldosterone and the aldosterone resistance, what is going to happen out? The first one, okay, the hyperkalemia. Why? Because without the aldosterone, potassium secretion will not be happen out, right? And this is one of the hallmark of the type 4 RTA, the hyperkalemia. So whereas the type 1 and the type 2, the type 1 and the type 2, they do present with hypokalemia, right? But here we do got the hyperkalemia, okay, itself. And then the metabolic acidosis. Why does the acidosis occur? So this is going to be the two-step process. The first, the lack of aldosterone is reducing the direct hydrogen ion secretion in the collecting duct, right? But more importantly, the hyperkalemia itself plays a key role. High potassium levels in the blood inhibit the production of the ammonia, inhibits the production of the ammonia. So there is no production of the ammonia in the PCT. And why does that matter? Because the kidney start excreting the hydrogen ion primarily by binding it with the ammonia to form the NH4, right? And which is then excreted into our urine, right? So but if ammonia synthesis is being suppressed out, the kidney cannot excrete enough hydrogen ion, leading to the metabolic acidosis. So that's why they have mentioned over here the reduced levels of the ammonia and the reduced ammonia secretion in of the hydrogen ion in the actually urine, okay? And definitely will lead up to the pH level that you can look up over here. Why we do have to remember that the pH is going to be the variable, because of the distal acidification mechanism is structurally now intact. The collecting duct can acidify the urine if given the right stimulus. So however, because of the hyperkalemia and the reduced ammonia, the total hydrogen ion secretion is impaired. What is going to happen out? Anything that is going to actually affect the suppression of the ammonia and going to affect the hyperkalemic state, right, into the RTA, right, the type 4, the pH could be variable. Why is that? Do remember one only reason, that the distal acidification mechanism is still structurally intact. Collecting duct can acidify the urine if given the right stimulus. And usually because of this hyperkalemic and the reduced ammonia, the total secretion is although impaired too. And let's look up to some of the causes over here, that is what is causing this type 4 RTA. The first one, everybody should remember of that anything which is decreasing the aldosterone production may leads up to the type 4 RTA, right? And this can be seen in the diabetic mellitus, right? The DM mellitus. It can be this is also a condition known as the hyperonism, right? This is also known as the condition to be the hyperonymic hypoaldosteronism. You can remember it out. And also in the patients, for example, like the ACE inhibitors, who take the ACE inhibitors, the patients like taking up the NSAIDs, right? NSAIDs, that's been written over here, and also the ARBs, right? ARBs, these are actually all those affecting the renin angiotensin aldosterone system. And whenever we do have that renal insufficiency, right? What is the another name for all that? The Addison's disease also happens in the Addison's disease, right? And whenever we do have the aldosterone resistance, this can be caused by potassium sparing diuretics like the spironolactone, the apellerenone, right, or the amyloride, or the other drugs also. So it can also be seen, with the certain neuropathies, for example, in the sickle cell diseases, neuropathies, the sickle cell disease is also to be seen of that one. And also one of the diseases, you can remember it out, that is due to the antibiotic use, that is the TMP SMX. And what is that? That is the trimethoprim sulfamethoxazole. Trimethoprim, okay, I write down over here, sulfamethoxazole. Okay, so the short form is TMP-SMX, right? And this can actually block the INAC channels. This can block the INAC channels that we have learned, the epithelial chlorium channels, in manner to similar as to the amyloride. Okay, so if I just try to bring up all these three RTAs together in simple comparison, the type 1, the distal RTA, the failure of the alpha intercalated cells, the hydrogen pumping in the collecting duct. The patient cannot acidify their urine, leading up to the more pH, right? And they present with the hypokalemia and also have higher risk of the calcium phosphate kidney stones. The type 2, the proximal RTA, right? Failure into the bicarbonate reabsorption. And also you have to remember it out that the pH is also variable, sometimes being the lesser and sometimes being the greater than 5.5, and that is actually the pH is low usually when the bicarbonate is below the threshold, and it is high when the bicarbonate is above the threshold. Okay, and the patient presents with a hypokalemia, often also considered to be the part of the Fanconi syndrome. The type 4, the problem with the aldosterone and its actions in the principal cells. The patient presents with a hyperkalemia, and the metabolic acidosis is also being driven by the hyperkalemia, suppressing ammonia production, right? Because no ammonia production. And this is the form you will often see in the diabetic patients which are on the ACE inhibitors, right? Or in the patients which are taking up the potassium sparing diuretics, right? So do you see how it all fits together? Each RTA type corresponds to a specific site, the mechanism we discussed in our initial journey through the nephron transport physiology. So when you understand the physiology, the clinical presentation becomes predictable. So a patient with the low potassium and the high urine pH points you to type 1. The patient with the low potassium and the history of the rickets or the drug exposures like acetazolamides, they point you out actually to the type 2. And the patient with the high potassium, the diabetes, the metabolic acidosis, or you can say the lower aldosterone levels, leads up to you to the type 4.